So what if I told you that there's one tiny gland, like pea-sized, tucked away at the base of your brain that's basically running the whole show? It's the body's master control center. And today, we're going to dive in to what happens when that control center goes completely haywire.
All right, welcome. We are breaking down pituitary disorders. And if you're a nursing student, you are in exactly the right place. We're going to cut through the noise, make this stuff easy to remember, and give you what you actually need to know, not just for your exams, but for when you're out there on the floor.
So here's our game plan. We'll start with a quick look at the pituitary itself, our master gland. Then we're going to tackle three really important disorders: acromegaly, diabetes insipidus, or DI, and its total opposite, SIADH. And then we'll wrap it all up with the key nursing priorities that tie everything together. Let's do it.
Okay, first things first. You can't possibly understand what's going wrong if you don't know what right looks like in the first place. So let's get a really clear picture of how the pituitary gland is supposed to work.
You know, the pituitary has two parts, an anterior and a posterior lobe, and they both have different jobs. Now, the anterior lobe is a real hormone factory. It makes a ton of stuff. But for our purposes today, we're zeroing in on just one: growth hormone, or GH. And from the back, the posterior lobe, we're going to focus on antidiuretic hormone, or ADH. So GH and ADH. Got it? Those two are the main characters in our story today.
All right, let's jump into our first disorder, acromegaly. This is what happens when that anterior pituitary just goes crazy and pumps out way too much growth hormone. And the key here is that this is happening in an adult. So this isn't about someone getting taller, it's about their bones getting wider and thicker.
You know, the thing about acromegaly is that it's sneaky. It happens so gradually, over years. A patient's hands and feet get bigger, their facial features become really coarse, their jaw might protrude, but it's not just about looks. All that extra growth hormone is causing chaos inside the body too. We're talking high blood sugar, high blood pressure. And those severe headaches, that's often from the tumor on the pituitary literally pressing on the brain.
So how do we nail the diagnosis? We use something called a growth hormone suppression test. Now think about it. Normally, if you chug a bunch of sugar, your body should go, whoa, okay, easy on the growth, and it shuts down growth hormone production. But in acromegaly, that pituitary tumor just doesn't care. It keeps cranking out GH. So if we give that glucose drink and the GH levels don't drop, that's our answer. That's a positive test.
So the most direct way to treat this is to just get the tumor out. The surgery is called a hypophyseectomy. And what's really wild is how they do it. They often go right up through the patient's nose to get to the pituitary gland at the base of the skull. And understanding that approach is absolutely crucial for knowing how to care for these patients after surgery.
Okay, this is huge. Post-op, your number one job is watching that little gauze pad they tape under the nose, the mustache dressing. If you see any drainage that looks clear and watery, like a runny nose that won't quit, that is a massive red flag. That could be cerebral spinal fluid, a CSF leak. And a CSF leak is basically a highway for bacteria straight into the brain. That's why we have to keep their head up and tell them, do not cough, do not sneeze, do not bend over. Anything that increases that pressure in the head is a big no-no.
Okay, let's switch gears. We're moving to the posterior pituitary now to talk about diabetes insipidus, or DI. And let's be absolutely clear about something. This has nothing to do with blood sugar or the pancreas. Nothing. This is all about water. Just think of DI as a state of extreme, nonstop dehydration.
So the root of the problem in DI is that the body isn't making enough antidiuretic hormone, ADH. ADH is the hormone that tells your kidneys, hey, hold on to some water. Without it, the kidneys just open the floodgates. They can't reabsorb water, which leads to those two classic signs, peeing constantly and being unbelievably thirsty.
And when I say peeing constantly, I am not kidding. Someone with severe DI can urinate up to 20 liters in a single day. 20! For perspective, you and I, we probably pee about 1.5 to 2 liters a day. This is a catastrophic amount of fluid loss. It's enough to send someone into shock if it's not managed quickly.
All right, lean in for this one. This is your money phrase for DI. If you forget everything else, burn this into your brain. The patient is losing all their water into the toilet, so their urine is super dilute. And since all that water has left the bloodstream, the blood that's left behind is super concentrated. Dilute urine, concentrated blood. Got it?
And the lab work tells the exact same story. You look at their urine labs, the specific gravity is crazy low, the osmolality is low, it's basically water. Then you look at their blood work, and it's the total opposite. High osmolality, and look at that high sodium. The blood is thick and salty from dehydration.
So what's our job? It's all about fluid, fluid, fluid. We are watching their intake and output like a hawk. We're getting daily weights. We're pumping them full of IV fluids to keep them hydrated. And, critically, we're giving them the hormone they're missing, that synthetic ADH, desmopressin, to finally tell their kidneys to hold on to some water.
Okay, get ready to do a complete 180. We're about to flip everything we just learned on its head. Now we're talking about SIADH, the syndrome of an inappropriate antidiuretic hormone. If DI is the body turning into a desert, SIADH is the body basically drowning in its own fluid.
And here's the beautiful part. You don't even need a new memory trick. You just reverse the one for DI. In SIADH, the body has too much ADH, so it's holding on to every single drop of water. This makes the urine super concentrated, and all that extra water hanging out in the bloodstream makes the blood super dilute.
And look, the labs are a perfect mirror image of DI. Urine-specific gravity is high, osmolality is high. But check out the blood. Everything's low and diluted. And pay close attention to that low sodium. That's what we call dilutional hyponatremia, and it is incredibly dangerous. All that extra water in the blood can actually cause the brain to swell.
So what's the number one most important treatment? We have to restrict their fluids. We have to stop pouring water into a body that can't get rid of it. We're often talking a restriction of less than a liter of fluid for the entire 24-hour day. And let me tell you, that is incredibly hard for these patients.
Our nursing priorities do a complete flip. We're not looking for dehydration anymore. We're looking for fluid overload. We're listening for crackles in their lungs, checking for swollen ankles, looking for distended neck veins. We're doing neurochecks constantly because that low sodium puts them at a huge risk for confusion and even seizures. So of course, seizure precautions are a must.
Okay, that was a lot, I know. So let's bring it all home. Let's boil this all down to the absolute core nursing responsibilities you need to have in your pocket when you're caring for any patient with a major pituitary issue.
At the end of the day, whether you've got too much fluid or too little, your focus is always on balance and safety. That means strict I's and O's and daily weights are totally non-negotiable. They tell you the story of what's happening with the patient's fluid status. You have to be vigilant with your neurochecks, and you're always watching those electrolytes, especially that sodium. It all comes back to keeping your patients safe.
All right, let's end with a quick scenario to lock it all in. You walk into your patient's room. They had that pituitary surgery through the nose about 12 hours ago. They tell you, I have this postnasal drip. It feels like a runny nose that just won't stop. What is the alarm bell screaming in your head right now? What is your immediate number one concern? Think back. You know this. That right there is your nursing brain in action.